Good afternoon. I'm Stephen Still with the law firm of Starnes Davis Flory in Birmingham. Um, my practice is devoted to defending healthcare providers, primarily assisted living facilities, specialty care assisted living facilities, and long or nursing homes in a variety of litigation, regulatory, licensure, survey matters, and over the last several months in a number of OSHA matters. Let me just be clear on one thing. I am not a clinician. I'm not a licensed healthcare provider. And as a result, my primary objective today is to be the opening act for Joanne Heiss, who is the person you all came to see today. I miss seeing everyone in person. I'm thrilled to be with you virtually. I look forward to seeing everybody, hopefully in person next year. And on behalf of Joanne and I, we are just thrilled to be a part of this wonderful and very unique program we're doing this week. So thank you for making us a part of this. Can we dive to the presentation, please? Pull that up. Thank you. For purposes of the format today, I'm going to do an overview of why this is important, why we need to spend our time here today, looking at your screens, at your phones, listening to Joanne and I talk. Joanne is then going to get into the substance of infection control and what you all need to be doing. And then we're going to get down to a question and answer period at the end. We have intentionally left a good bit of time at the end of the program for questions and answers, and we want to answer each and every one of your questions in this, again, very unique format. If I were speaking to you live in person, I'd tell you to interrupt me at any time with questions, but I can't do that today. So we're going to do our best to answer your questions as they're queued up at the end of the program. The topic that we're going to address is infection control. I'm going to address the liability and exposure that we all face in the infection control arena. And then Joanne is going to get to really the substance of how to build a firm foundation upon which to base your infection control policies, for your facilities, for your staff, and for your residents, and right now, or one day soon, for your visitors. Infection control has been an important topic for Joanne and I and our firm over the last several months, as I know it has been for you all, and becomes increasingly more important and more critical each day. I'm going to focus on three primary areas of importance today, and those are the impact infection control has on the litigation process and your exposure for being sued and the value of the lawsuits if they're filed. Secondly, its impact on survey, regulatory, and licensure issues. And then third, for OSHA, how it affects the people that you all depend on the most, and that is your staff. The program that immediately preceded ours was excellent and dealt a lot with morale and staff issues, and I think this dovetails very, very closely with that. So again, we're going to look at how this affects you as a facility, your licensure, your ability to keep your doors open, your residents, the people that you care about, the reason you got into this business to help those people, and your staff, again, the people that you depend on day in and day out. Could we cue the next slide, please? I like to start with this slide, even though it's admittedly these deal with nursing home verdicts, because I think it shows why this is important, why we all need to pay attention to the risk and exposure we have through litigation, through lawsuits, through settlements, through plaintiffs' lawyers sniffing around in our facilities. There's a couple of verdicts I think warrant some attention. The first is the Florida verdict, $200 million, very substantial verdict. It's a 92-year-old, again, nursing home resident, not an assisted living resident, and a 2-month residency. So a very, very old resident, at-risk resident, very short admission. Second is the Kentucky verdict, $8 million personal injury lawsuit. Again, a nursing home resident in the mid-80s, less than a 2-year residency. And I put in this Bessemer verdict because it's just down the street from my office. Can we skip to the next one, please? And I want to mention this West Virginia verdict just because of the size of the verdict, $91.5 million, an 87-year-old resident, and a 3-week residency. Again, an older resident, a short admission, short residency, and a very substantial verdict. This is important because, as you know, and as we've learned, infection can set up very quickly and can spread very rapidly. So these verdicts admittedly all precede COVID, but I think the size of the verdict shows why this is important, and I hope we'll get everybody paying attention here this afternoon. Um, I should also point out there have been a number of recent verdicts and substantial settlements in the both assisted living and specialty care assisted living arena here in Alabama recently and across the country preceding COVID. And as you all know, you don't need me to tell you this, there's been heightened awareness and heightened scrutiny of infection control measures since COVID has come onto the scene of our facilities. So again, this is very important. Now, I know what you're thinking. He's talking about apples and we're talking about oranges. This is the Assisted Living Association. This is not the Nursing Home Association. He's talking about nursing home verdicts. And that's correct. I am. This is important because for a long time, assisted living facilities in Alabama had the benefit of being largely under the radar with litigation, with lawsuits, and with plaintiffs' lawyers. And that was a good thing. It was a very good thing. Unfortunately, it is no longer the case. As I'm sure you are all aware, if you're not, I don't know how you've missed it. Lawyer advertising has gotten very, very big in this state through billboards, through social media, through television, through just about every other way you can communicate with people. It's out there. And unfortunately for you all, you are on their radar, perhaps never more so than right now. I believe the plaintiffs' bar across the country and right here in Alabama is closely monitoring both COVID and the infection control measures that are rising out of it. And we, unfortunately, as an industry, are first on their radar. Social media, I don't have to tell you what all is on Facebook, what all is on Instagram, what all is on Snapchat. People are not afraid to post negative reviews, negative comments, negative statements about healthcare providers, both facilities and individual nurses, aides, physicians, healthcare providers on Facebook and other social media platforms. Nor are they hesitant or reluctant in any way to share with the public at large what they perceive as bad outcomes in their loved one's care, bad surveys, deficiencies, poor infection control measures, anything of that nature. Unfortunately, we've all seen it, and I think it will only continue to get worse. It is very hard, very easy these days to hide behind a screen. AL.com. There have been a number of articles. There was a time when they were weekly, if not daily, addressing COVID-19 and infection control in the long-term care industry. Now, admittedly, there were some very positive, very good articles, and there have been some good articles on LinkedIn and other social media platforms. But unfortunately, with that, there has been a lot of negative press and negative publicity. And there is, again, a very heightened awareness by our society and our plaintiffs' bar and those family members who have loved ones admitted to our facilities of what's going on across the long-term care industry right now. And again, I'll just reiterate that the facilities that you all own, run, and work in are on plaintiffs' radars right now. Some of the biggest firms and some of the best plaintiffs' firms in the state of Alabama are currently looking at what's going on in our industry. And again, for that reason, what we're talking about today and what we're talking about over the course of these several days is very, very important to us. Can we cue the next slide, please? I like to point out these two things when I give this talk. One is that, what we do on a day-to-day basis to prevent bad regulatory outcomes can carry over to litigation. And what I mean by that is this. It's no secret that regulatory agencies are taking a very heightened and strong and critical look at infection control measures right now, as admittedly they should with everything going on in the world. But what I've seen over the course of my practice and what Joanne and others have seen is that a bad regulatory outcome, a deficiency, a bad survey history, a licensure issue very quickly spreads to a either settlement demand, record request, or lawsuit. So they tie together very quickly. And I'll tack on recently, OSHA has been hyper aggressive with infection control measures and with COVID, and it also is leading to a number of issues in this area. The Beasley firm, for those of you who are not familiar with them, is probably the largest plaintiff firm in the state of Alabama and one of the oldest plaintiff firms, has been very aggressive in pursuing assisted living facilities over several years and are still doing so today. And they are one of the first plaintiffs firms to actively advertise and link together the dots between a regulatory outcome, a bad survey, and potential exposure with litigation. I apologize for the small print in this article. I'm happy to provide a paper copy to anyone who would like it. Just reach out to me by email. I'm happy to scan it to you. This is a page from the Jerry Beasley report, which goes out, I think, quarterly, if not every month, to every lawyer and law firm in the state of Alabama, and I think some other states as well. And it is provides an update on what they're doing. And this is one addressing its update on nursing home litigation. But the opening sentence addresses the assisted living facilities and the assisted living industry. And it goes on to state that these facilities, assisted living facilities, are distinct from nursing homes, primarily because they do not provide the same level of health care to the residents. They then talk about the policies and procedures assisted living facilities are required to have. As you know, those would include proper infection control measures. It says the Alabama Department of Public Health requires that assisted living facilities maintain adequate staff to meet the care needs of all residents, and goes on to discuss additional requirements and duties that in their interpretation, we're required to have. And it ends with this, I think is very important. If you need more information, contact, and it lists the lawyer's name, a lawyer in our personal injury products liability section, and then helpfully provides several phone numbers and an email for that lawyer. So again, they are educating the public at large, including people who have loved ones and family members sitting in your facilities right here today, that you are providers, that you're out there, and that they are happy to represent families and residents of your facilities, and then provides contact information for them to reach out to them. Again, y'all have had the benefit as an industry of being relatively under the radar, and that is no longer the case. So for that reason, again, I encourage everyone to pay close attention to what we discuss, not just over the next hour, but during the several days of this conference, because it's all very important. Could we skip to the next slide, please? This is another example of how, like Beasley Allen suggests, a bad outcome, a bad regulatory or survey outcome or deficiency can tie into litigation. And it's two ways. One is a family member has a bad outcome in an assisted living facility. The family or responsible party, sponsor, whoever it is upset and goes to see a lawyer. The lawyer, in an effort to, quote, bolster their case, instructs the family member or the resident to file a complaint with the state and to work up some kind of regulatory deficiency or regulatory citation. Now, let me back up. There's ways to address that in litigation, but it's a headache and a lot of time and money you all don't want. The other way is a facility has a bad survey, an infection control deficiency, an infection outbreak, a COVID outbreak, something like that. And that sparks either staff members to complain to OSHA or to complain to lawyers about an unsafe work environment, or in effect staff members or, residents or their family members to contact a lawyer. Again, they work together, and we have seen, particularly in the long-term care industry, plaintiffs' lawyers get very creative in trying to work hand in hand between the litigation and the regulatory component of what's going on. OSHA is something, admittedly, until March of this year, I knew very little about and thought very little about, but it has unfortunately become a very popular, maybe not popular, but a commonly used word in our practice, and has been on the radar of our clients as OSHA has, again, determined that COVID-19 presents a recognized workplace hazard. And we're shifting gears here from resident care to your staff, who are, again, the people that have been with you and you work with day to day. But we've seen OSHA be very aggressive in pursuing infection control measures, COVID-19 measures within both the assisted living arena and the nursing home arena. They have been more active with on-site investigations, with staff interviews, with, hate to call it a survey, but again, an investigation, and looking at that. We have worked with clients to develop their best practices for if and when they do come into your building. And let me just say one thing that we encourage people to do is I trust and hope you all have your infection control policies and procedures and protocols in place. I trust and hope, and I'm confident that they have been revisited over the last several months in light of everything going on in our industry, and that there are steps you are all taking at your individual facilities to address that. And this is the first thing we told people, is that if and when the OSHA inspector comes at your door, make sure the compliance officer with OSHA follows all of your PPE, your screening policies, their procedures. Make sure that they're doing everything every other visitor or healthcare provider person would be required to do during the visit to the facility. If they don't do it, tell them they are not welcome in the facility at that time. Let me mention one other thing that we've seen is that staff members, your employees, are not required to voluntarily sit and meet with or be interviewed by OSHA investigators. But we have seen a heightened level of aggressiveness by OSHA with subpoenas and other measures to compel them to participate and to interview with them. So again, this is just something to be on your radar. 3 things with the OSHA investigation. 1, again, I trust that you all have policies and procedures in effect on infection control. Joanne is going to address some of that. Secondly, we need to prove that the staff and the employees have been trained on them. Third, we need to show the staff understands the policies. They understand what they're supposed to do. And if that means repeat training, repeat in-servicing, then that's what we do. And finally, I think most importantly, we need to show that the staff and we as a facility are following those to the T. And that again begins the moment the OSHA inspector walks in the door, when we ask them to submit to the same level of screening and to submit the same level of infection control precautions we use for everyone else who enters our facility. Can we skip to the next slide, please? This is one example of about 1,000 pages of materials that has been provided by either the CDC, the state of Alabama, CMS, Medicaid, any organization you can think of, over the last several months addressing COVID-19. I know there has been a ton of material disseminated. It changed frequently, sometimes before you had a chance to look at it, but know that it's out there and we're expected to comply with it. Again, what I want to stress for the brief introduction I'm doing for Joanne is the 3 primary areas of exposure we have with infection control, and that is through litigation, through the survey deficiencies, which can, as you know, result in licensure problems, regulatory problems, and civil monetary penalties, and OSHA issues, which affects your staff, which affects what we talked about the last hour, morale and staff psyche and things of that nature. So again, it affects all 3 of those. To prevail in these matters and to prevent bad outcomes, it is absolutely imperative that we have a firm foundation for infection control and that we follow it. And just in case what the CDC says and what the state of Alabama says and what Jerry Beasley says and what Joanne and I say is not important, I want to share with you one other illustration of why it's important to have a solid foundation. Anyone who listens to my teaching and follows it is wise, like a person who builds a house on solid rock. Though the rain comes in torrents and the floodwaters rise and the winds beat against that house, it won't collapse because it is built on bedrock. But anyone who hears my teaching and doesn't obey it is foolish, like a person who builds a house on sand. When the rains and floods come and the winds beat against that house, it will collapse with a mighty crash. People have been talking about the importance of a firm foundation for thousands of years. Prior to March of this year, if you had a firm foundation and you followed it over the last several months, I think you're probably sitting very comfortably right now. If you did not have a firm foundation, and if you have not followed it over the last several months, I think you may be looking at some potential exposure for the reasons we talked about earlier. How do you build a firm foundation? I'm going to now turn this over to Joanne Heiss, who's the real expert, and let her talk about how best to do that.
Hi, good afternoon. And like Ms. Adcock, I find talking to the computer to be a little bit daunting. I'm used to seeing faces and getting feedback, and I far prefer that format than this, but we're going to, deal with the cards we've been dealt. We're going to play our hand. So I am a licensed nursing home administrator. I'm a registered nurse. I'm certified in gerontology and in infection prevention. So when we talk about infection control, one of the most difficult things I find for most audiences is that you have to understand the basics. And fortunate or unfortunate, you, the listener, my audience, you have been on the front lines of something that you really were not very well prepared for, because infection control, there's not much said about infection control in the assisted living and or the SCALF regulations. So, and I'm also used to walking around the room and talking with my hands. So it's a big adjustment for me not to get up and wander around the room. So excuse me, I will try not to do that. So I think that we need to think back to 7 months ago. I transitioned from being a director of nurses and for 25 years in a long-term care facility. I also did expert witnessing for long-term care facilities, both nursing homes, assisted living, and SCALFs all over the United States. I knew how to do that job. But when we sold our facility, and then I came to work at Starnes, Davis, and Flory, I didn't know how to do this job. I had the foundation though, but I really, I wasn't sailing on smooth seas. It was rough. It was rocky. I had to learn new things. And over the last 7 months, in February, we were all sailing on, you knew how to do this job. You know how to run your assisted living. You know what to do. You know the regulations. You know the policies and procedures that allow you to implement those regulations and give good resident care. So unfortunately, and I will just tell you, is that at the end of February, when all of this started to hit, I was on a long promised vacation in Hawaii. And so this is what I was basically looking at. This is not Hawaii, this is actually Gulf Shores. But people were just sailing along, everything's fine. Well, then March comes along and things get a little bit hairy. The winds raise, the seas rise, and things are almost, I think if you look back here, you can see this is actually Gulf Shores as well, are not quite recognizable as they are now. And then this is now. 6, 7 months later, this is what we've been dealt with. And to go back to Stephen's parable of the man who builds his house on solid ground, or the man who builds his house on sand, we all know what happens with a sand castle. I go out and I build a castle, and when the high tide comes in, it's going to be washed away. And I think this is what we feel like. Your censuses are down because so many of your facilities, the COVID, they've had to transfer to a higher level of care, and we've lost so many of our residents in our long-term care industry, whether it be assisted living or a nursing home or a SCALF. We've all lost residents. We've all lost loved ones. And I think this is what we think of. This is actually Mexico Beach. And they talk about, they use this White House in the foreground because it had been built recently before the hurricane, I guess it was last summer, that came through Michael and wiped it out, and said, we built it with every safeguard we could. It was the only house that had like no damage other than some equipment that hadn't been secured underneath the house. So if we think about that, that's what infection control is. There are some basics to infection control that we must understand. Over the last 6 months, I've had the privilege of being allowed to go into a couple of dozen facilities across several states and see what they were doing, observe them, their practices for what were they doing to implement the COVID-19 guidelines. And you're right, they change every day, but there's one thing that never changes in infection control. And if I could have you raise your hands, I know what you might say, but I'm going to answer the question for you on the next slide. But I've asked this question for 25 years to probably 1,000 audiences in giving in services and talks to them about infection control. What's the number one way to fight the spread of infection? I hear everything under the sun, and finally they get to the right answer. The right answer is hand hygiene. And I am not one, I don't like to be read to in an in-service, and I don't want people to read to me. So I'm not going to read to you, but we're going to present some basics of things about good infection control that you can then come back and look at, or if you need to ask questions. Both Stephen and my contact information, emails and telephone numbers will be on the screen, so you can then call us, email, send us a chat question, whatever. But hand hygiene, that is the number one way to prevent the spread of infection in any environment, whether you're at home, an assisted living, hospital, going to Walmart, hand hygiene. And if you notice, I did not use the word hand washing, but hand washing and hand hygiene are considered by the CDC to be synonymous. They are one and the same terms. So the very first question I would ask folks whenever I'm walking through their facility or interviewing them or doing an in-service, when are the 5 moments, and this is actually the World Health Organization's, the 5 moments when a healthcare worker Thank you. I'm sorry. We had a slight technical difficulty and I had to make a slight change. All right. So the World Health Organization says there are 5 moments when a healthcare worker must perform hand hygiene. So hand hygiene is going to be synonymous with hand washing. And the first 2 are easy: before and after resident care. All right, that's easy. Contact with any kind of blood or body fluids. So for our environment, that could really be any time. If you have a resident who's incontinent, they sneeze, they cough, those type of things. Anytime you're donning or doffing, putting on or taking off any kind of personal protective equipment, And of course, we're going to talk extensively about personal protective equipment. And performing any kind of an aseptic or clean procedure. So in our environments, if you're assisting someone with eye drops, that is technically a clean procedure. Med pass, any kind of putting a Band-Aid on someone, that is a clean aseptic procedure. All right, so hand hygiene is synonymous with hand washing. There are two acceptable methods to do hand hygiene: soap and water or an alcohol-based hand rub. And we've all heard more than we want to about hand sanitizer. But I'm going to ask Stephen this question because he's actually in the room. And what does the CDC say is the most what is more effective, soap and water or alcohol-based hand rub?
Alcohol-based hand.
He is absolutely correct. And you're going, I've gotten mixed questions, and if I had a room full of 100 nurses, 90% of you would say soap and water. It is more effective. And technically it is not, all right? There's a reason why it's not. Number one, there is nothing that will kill the germs in that soap and water. And we're going to talk about why you probably don't want to be using an antibacterial or an antimicrobial soap, because you're actually opening up your residents to resistant bacteria when you use antimicrobial soap all the time. So the CDC says that hand sanitizer with 60 to 95% alcohol in healthcare settings is the recommended method, unless your hands are visibly soiled. Well, I've got gloves on and they're dirty. Gloves are not a substitute for hand hygiene. Okay, if you have dirt, if you can see dirt on the gloves, or let's talk a little bit more clinically, feces, urine, vomit, blood, mucus, then you need to be using soap and water, unless there's nothing else there. If you don't have access to soap and water, then hand sanitizer is obviously preferable over just putting on a new pair of gloves. Okay, they are also, your hand sanitizer are generally less irritating to your hands and are more effective in the absence of a sink. Now, one of the things that, and there's the reference to that if you ever need to find it again. All right, so however, though, there are 4 times the CDC says that you must wash your hands. And some of this is going to be common sense. The very first one is if they're dirty. If I'm outside working in the yard and I've got dirt on my hands, I'm going to wash them. I need to use soap and water to get whatever it is, the dirt off. Second of all is before meals and food preparation. So technically in your kitchen, you should be using soap and water versus hand sanitizer. Okay. And that's also applicable to before we go to eat our lunch or our meal break or take a snack or have something. This is also one of the reasons why they really don't want, the CDC discourages greatly healthcare providers eating in their work area. They want you to leave the work area so you perform hand washing before you ingest food. And there's actually a relationship between ingesting food in your work area and contracting hepatitis. So people need to think about, I'm out here passing ice water to these residents, or I've just changed the sheets on Mrs. Jones' bed, or I've put a load of clothes in the laundry. Oh, wait a minute, let me have a drink of my Coca-Cola, which I have hid in the laundry room. After toileting or using the bathroom, this is an obvious thing I should be doing. And the last one, nobody ever gets. And in your environment, it's highly unlikely that they ever would get it. And that is if they have C. diff or the norovirus. Once in a while, you might get a norovirus outbreak in an assisted living, but if you shouldn't be caring for somebody with C. diff in your facilities. It requires contact isolation, and I don't think you're prepared to do contact isolation. Okay. All right, so soap and water. And I'm only going to talk about the one part of this screen that everybody knows how to wash your hands. I think what's applicable here is that it used to be for 15 seconds and the CDC now says 20 seconds. And so that's been a change that people haven't always adapted to. And I know that some of the guidance we've seen on TV, but for healthcare providers, you should be washing your hands vigorously with soap and water for 20 seconds. The very last thing is that originally when I became a nurse in 1982, we were told to rinse your hands, dry them thoroughly with a disposable towel, and then to take that towel and turn off the faucet. No, you want to take the towel you dried your hands off with, discard it, and turn the faucet on the sink off with a dry paper towel. How do you use hand sanitizer? Because I've seen hand sanitizer used in a variety of ways, and most of the time it's not correct. First of all, if you're getting a handful of hand sanitizer, that's too much. You need about, a quarter or a 50-cent size piece, enough that you can thoroughly coat all surfaces of your hands between your fingers and rub them until they're dry. And what happens when you get too much hand sanitizer? Your hands are so wet, they end up wiping them off on their clothes, a towel, a paper towel, things that are not going to be appropriate. When you use hand sanitizer, you must rub them until your hands are dry. There is actually, I didn't mention this, but I'm going to bring it up, and it's about soap. So I really had no idea how soap worked because I thought there was something magical in soap that killed all the germs on my hands, and there isn't. All right, so all soap does is it binds together with any germs on your hand and allows it to stick. The germs stick to the soap so you can then rinse them off. That's all it does. And oops, I didn't mean to go forward one, but I didn't want to give that one. Let me go back. And I would also say this. So when you're talking about antimicrobial soaps, and we tend to want to use Dial, that's a name brand, but we see we're antibacterial, antimicrobial. I would discourage you from using them, first of all, because it dries your hands out. Second of all, it kills all the normal bacterial flora that live on your hands. Basically, Staph aureus lives all over your body. And so consequently, when you kill the Staph aureus, the staph is sort of like, I hate to say it, it's like a chicken snake that eats poisonous snakes. That Staph aureus eats the other resistant bacteria that's living on your body as well and overcomes it. So your residents become more susceptible to VRE, MRSA, all of the things you don't want them to have. So it is much better to have just plain old soap to wash your hands, and to obviously liquid soap. You don't want bar soap because germs live in that as well. One of the other reasons, and I didn't mention this before, that the CDC supports alcohol-based hand rub other than the alcohol kills the germs is it's faster. If you will stand and time yourself from the time you rinse your hands off, you get soap on it, you do it for 20 seconds, you dry, you turn it off, your water. It takes about a minute and a half. It takes 20 seconds to do hand sanitizer. So obviously faster is going to mean people are going to be more compliant because it doesn't take as long, okay? And there's this caveat here that says gloves and the use of baby wipes are not substitute for hand hygiene. Gloves are nothing but a barrier. They do not and never will be a substitute for hand hygiene. And how many times have you seen people put a pair of gloves on and go all over the room and touch everything and never wash their hands, and they've contaminated the whole room? We're going to talk about glove contamination in a minute too. All right, so we've talked about soap and water. This is the way, the dry one. Let me go back here. You know what? Oops, you know what? I'm going the wrong way on the slides. Sorry, excuse me. I just went, here we go. The one aspect of the CDC hand hygiene policy that nobody likes to talk about and that is false fingernails and nail polish. And what the CDC actually says is that anybody who is in a high risk environment should not have false nails, nails polish, even clear nail polish. And if you notice, see all this jewelry? It's beautiful, but it is a harbinger for germs. So you have to make a decision in your environment, are we high risk? And then you have to apply the CDC policy or their recommendations to your policies, excuse me. So germs, they live under artificial fingernails. I've seen pictures where people's, the horrible fungus and things that people have gotten in their nails, and infections that have required hospitalizations because they wear false fingernails. But they live under everything, and it's still going to be there before and after you wash your hands or do any kind of hand hygiene. Well, if I can get it to, oops, here we go. All right, don't wear them, any high risk, and keep your natural tips less than 1/4 inch long. And actually, some studies suggest that there are more germs under your rings than actually on your hands, especially without rings. Just a thought you might want to consider about false fingernails and jewelry. Hand hygiene compliance is really the bedrock of your facility infection control program. And you need to be able to validate and verify your expectations. So it's not enough to just teach folks what they're supposed to do. You need to also be watching what they're doing. I make it a practice when I go in to do an infection control inspection, I just stand in the hallway. You know, the first hour I'm there, you know, people are very conscious of what you're doing. And then after you talk to them a minute, they're going, oh, it's just Joanne. And they then revert to what they would normally do when I was no longer that fly on the wall. And you have to watch all their behavior. You have to watch what they're doing in the kitchen, how they're washing your residents' clothes, how they're making a bed, how they're vacuuming, how they're cleaning the rooms. And you have to set the example. So if you're touching the residents and touching all of them and never doing any hand hygiene, neither will your employees, your caregivers. And constant feedback is incredibly important, and not just talking about you did a bad job at this, but reinforcing their good behavior, great work. My former employer had a saying, he said, it is not what you expect, it is what you inspect. It's not enough to tell them what to do. You have to also inspect what they do and give positive reinforcements for those things. All right, so let's talk about personal protective equipment. Woo, I'm going to have to fly because there are a couple of things here. PPE, it's some kind of clothing to protect against infectious materials. You've got gloves, gowns, goggles, face shields, masks, and respirators. And this is a personal pet peeve of mine. We can talk about gloves, but I really want to get to masks, okay? But what are gloves supposed to be doing? Gloves, literally, they're just a barrier. They're nothing more than to protect you. They do not replace hand hygiene. And you must always work from clean to dirty, all right? And you have to eliminate touch contamination. And by that, a person puts on a pair of gloves and they think it's okay to touch everything in the room. So I can strip the dirty sheets from Mrs. Jones' bed. I can clean the bathroom, and then I can go and clean the sink. I've gone from dirty to clean, all with the same pair of gloves on. And I think it's very important. And the very last part of this deals with clean to dirty, is that your staff has to understand what's clean, what's dirty. And that's your job to teach them in their task. This is dirty, this is clean, okay? Masks, or I'm sorry, and if you've got to make sure you're changing the gloves if they're torn or visibly dirty, and you're putting them in the waste can, not on the floor. Let's talk about face protection. I just love face protection. And I'm going to let it get all the things here. All right, and I want you to notice is that I have my trusty little mask, okay? And I want you to notice that the blue side is out, the white side goes in, not, I've seen everything under the sun. Wearing the white side out. This is the one I really like, okay? Or this one's the better one. Or actually today, I saw somebody whose mask was tied around their ponytail. I'm not sure what good it was doing the ponytail, but it was quite cute actually. So just remember that the mask is meant to give you some kind of protection on your face of things that will get in either to your nose or your mouth. Goggles, they need to protect that's all they do is protect your eyes. They don't protect anything else. They just, personal glasses, my glasses do nothing as far as protecting the side of my eyes from germs, from getting into your face. And there are some goggles that have an anti-fog feature, but one of the things I hate about a mask is that I wear glasses, and if this is not secured, my glasses are just fogged all the time. I love face shields. I know of 2 facilities that have basically, and I don't want to say they've been COVID negative or have had minimal, and that is because in the very beginning, the facilities enacted masks and face shields April 1. And they have been very successful in having very limited COVID residents and employees. They kept things from spreading. But a face shield, it's meant to protect your forehead. It starts here, goes all the way down. And one of the benefits of a face shield, it keeps you from touching your mask. People wear them, they're touching it all the time. This is the dirty side, okay? This is the dirty side. We don't want people touching their masks. And you probably spend 50% of your time in your facility saying, please don't touch your mask. I actually found this, I can't remember, I think this came from Washington State, but it actually talks about the exposure with mask, whether you're high risk, with mask, without a mask. So, and I want you to look at this bottom one. So I've got a COVID-19 carrier with a mask on, and I'm 6 feet away. And I have my mask on, we both have a mask, and we're both social distance. I have a very low or no exposure to the COVID, okay? There actually were some projections that it was less than 2% exposure rate, but nobody's been able to prove that, okay? So, and I know you all seen this, how to properly put on and take off PPE. And we're going to buzz through the transmission or expanded precautions because we are right at 12 minutes to 4. So standard precautions used to be called universal precautions. And universal precautions are basically, I assume everybody I come into contact has something I don't want. I used to work at UAB on the infectious disease ward when AIDS was an epidemic in the 80s. And it reminded me so much, everybody's afraid that, oh my gosh, if I sit next to somebody waiting for the bus or waiting in a physician's office, I'm going to get it. And that is really where we're at now. We've come back to the same level of hysteria because it's all unknown. So it recommends PPE and other infection control practices. Now, when you say other, hand hygiene is what they're talking about. Hand hygiene and environmental cleaning to prevent the transmission in any setting. And then we have to figure out what do we need based upon the clinical interaction with a resident. And I will just say this, if you get beyond standard precautions, you might consider that they are not suitable for your environment. Assisted livings have very strict rules and they must be able to direct their care and those type of things. And if they can't do that and they have an infectious disease, this is really a skilled service that is probably you're not going to need or not a service you shouldn't be giving. Obviously, when do you wear gloves, gowns, face masks? I personally, when I go into any facility now, I have my own personal face mask that I disinfect after every use. And I put on my N95, all right, or a surgical mask, and I put on that face shield because then I'm not touching, and I know that the #1 place for me to be exposed is going to be my eyes, my nose, and my mouth. And if I'm touching it, I may get it. So expanded precautions are either contact, droplet, or airborne. So sometimes you might think about you need a gown and gloves, okay? And only because in your environment, if somebody has had an incontinent episode, you might need to put something on to protect your clothes from getting feces and urine all over. You should probably not be doing droplet precautions, and for sure you can't be doing airborne precautions because you don't have any negative pressure air rooms. So what type of PPE would you need? And there are two things on this screen that you should not be doing, you should never do. If I was able to have an audience in front of me, I'd ask you to raise your hands. So when we go to the next slide, all right, let's talk about it. Oops. Giving a bed bath. There's no PPE that should generally be required. You might put on gloves, but you shouldn't really need to do PPE. All right, however, transporting in a wheelchair, never need PPE for that. All right, an emergency where blood is spurting, okay? Well, you might need to put on some PPE because sometimes your residents fall and they get a cut and their head's bleeding. And before the EMS gets there to transport them to the hospital, you may have to provide something. So in an emergency, you may need to have gown, gloves, face shields, goggles available, okay? Second of all, drawing blood, gonna need gloves. Cleaning an incontinent resident with diarrhea, you need gloves with or without gloves with or without a gown. And last but not least, taking vital signs, okay? So these, you might consider you need some PPE. All right, now we've talked about this and I could talk for an hour about clean and dirty, all right? But all of your staff, your caregivers need to understand the difference between clean and dirty. What is clean and what is dirty? And when I'm teaching your direct care staff, your caregivers, your nursing assistants, your LPNs, your med techs, those type of things, I want them to think about simple things they do. And the most simple thing is that whether you have a dishwasher or not, sometimes the dishwasher breaks down. Everybody has to wash dishes. What utensils do you wash, or what part of the dishes do you wash first? Do you wash your glasses? Do you wash your pots and pans first? No. You wash your glasses and your utensils first because, first of all, the water is going to be the cleanest. And second of all, that's what you eat with. You're going to wash the dirtiest thing first. And if you think about pots and pans and even putting things in your dishwasher, all of you do a basic infection control principle, which is you rinse off the big junk before you put it in the dishwasher. You rinse off your dishes, you scrape your dishes before you put them in the sink to wash them. Laundering clothes. You don't put a whole load of dirty clothes in the wash machine and then with your same hands, get out a load of clothes with those same gloves, the same thing. You actually should wash your hands before and after. So some very specific facility tasks that you can do and you can teach your folks can mean the world of difference between an outbreak of any infection. I am a fan of what we call the KISS method. Keep it simple. Now, there's supposed to be another word on the end, but I'm not going to say it. Well, we need to keep things simple because the more detailed we get, the more difficult it is for our staff members to comply with difficult tasks. So I'm moving right along. This is our new normal. I hate to say it. I really don't like it. I don't. Any of you who knew me 6 months ago, I have the COVID 6 inches of hair. I elected to go from a very short pixie cut to, well, I'm not sure what my husband calls it, my mop. But this is our new normal. And I think it's here for a while. So we have to adapt. So I appreciate Ms. Adcock saying we're very resilient. I don't envy any of you who are on the other end of this virtual webinar because your jobs were made exponentially more difficult on basically March the 13th, because that's when all the guidance went out and we started shutting down. So years ago, when I first went to my hometown was Selma now to practice, I was going down the road and I saw this little billboard on a church, outside the church. And it basically said, and this is a quote by John Wooden, if you don't have time to do it right the first time, are you going to have time to do it over again? And I think this is back to the principle of we have to get back to the basics. We have concentrated so much on COVID, and I know you all are probably overwhelmed and excuse it, sick of it. We're all sick and tired of hearing about coronavirus and COVID and a vaccine and all of these issues. But I would say to you is that if you're still fighting COVID, or if you're still fighting any kind of thing, if you have residents even going out with frequent urinary infections that have incontinence, you need to look at your practices and what you're doing. And you need to get back to basics. And that includes your hand hygiene, clean and dirty. And when do I appropriately wear my PPE and what do I do? So we have, believe it or not, we have a couple of minutes for questions. I'm going to have to go to, and this is our contact information. Oh yeah, I've got to unlock it. It doesn't like anybody's business. Okay, so I'm looking at my thing. I don't see anything on the Pubble, but maybe my assistant, my trusty assistant, can help me. I don't have any unread. Here we go. For me, no questions. Great. I'm good with that. If you do have any questions, please feel free to email Stephen or myself. It's pretty simple. Stephen's S. Still or J. Heiss at starneslaw.com. These are our direct phone numbers. You're welcome to leave an email or text us in any way. Thank you so much. It's been a pleasure, and I hope that you learned the basics of infection control.